willingness to listen to honest feedback and change the established way. On the other hand, surgeons thought of cardiologists as being too theoretical and unwilling to work as hard as they do. But what happened over the last few decades, the scope of catheter interventions grew rapidly in this country, and more and more defects could be fixed in the catheterization laboratory. So there are more potential for competition and perhaps even conflict between the surgeons and surgery and cardiologists and interventions. So why do we need the team approach? The surgeons is needed to bail out the intervention cardiologist in the event of complications such as embolization. Similarly, catheter interventions are occasionally required early in the postoperative period to deal with residual issues. Many patients require both modalities for optimum results. If a surgeon would like to have a refinement in technique to improve immediate and long-term outcomes of surgery, insights from imaging contribute immensely. The transesophageal echocardiography for immediate postoperative assessment of repair has necessitated the presence of cardiologists in the operating room. And it is also often necessary to the pediatric cardiologist to be actively involved in preoperative stabilization prior to neonatal cardiac surgeries. So a patient does not belong to anyone in a proper pediatric heart program. So the team as a whole collectively responsible for the patient. So once a patient gets admitted to a pediatric heart program, individual members looks after specific issues. Like the pediatric cardiology will do the preoperative assessment, and the cardiac surgeon will fix up the lesion, and they will hand over the patient to the intensive care team till discharge. So what are the key requirements for establishment of a team? The first and foremost is skills of individual team members. A reasonable level of basic competence, skill, and experience of all the key senior members of the team in their respective areas is a minimum requirement for the team to function. Often these skills develop over a period of time as the pediatric heart program matures. And needless to say, without mutual respect and mutual trust, this cannot happen. And during the period of maturation of program, key team members need to encourage, support, and nurture each other. And for me, the core requirement is understanding each other. Surgeons in particular need to be understood. The years that they spend in training, the physical and mental stress that they undergo on a daily basis, the responsibility they shoulder towards the patient's family could all translate into some changes in personality that may be hard to accept initially. So I'm a surgeon's friendly cardiologist. I always support the blooming cardiac surgeon, like here we have Dr. Rokunuzzaman Selim, and I always try to understand them. So the process of understanding, to improve the process of understanding, we need to develop a keen, the surgeons and cardiologists need to develop a keen interest in each other's specialties. The cardiologist should step into the operating room and watch the cardiac surgery. The specific difficulties encountered are better understood in this way. Similarly, the surgeon should give an active interest what the cardiologist does. The surgeon's input can enormously improve the quality of information provided by imaging. Poor communication of patient details is often at the root of number of potential conflicts. Meticulous documentation in case record is an essential requirement. Combined weekly meetings perhaps helps the process immensely. In the postoperative period, good communication is vital at all the times. Situations with changes in the caregivers from ward to ICU to step down are particularly vulnerable to lapse in communication with potentially serious consequences. So communication with patient's family needs careful attention and can be a potential source of conflict among the team members. And it is necessary to address differences and resolve them regularly in an amicable fashion. Formal forums for collective decision is very important. Combined meeting for preoperative decision making should be conducted regular intervals, and all the team members should attend the meetings. This meeting serves as an important opportunity to clarify doubts, discuss specific preoperative concerns, plan specific strategy in potentially difficult situations, and anticipate and prepare for post-operative issues. Additional forum for collective decision making is the daily ICU round, which ideally should be a combined round involving senior members of anesthesia or intensive care, cardiology, and cardiac surgery. Role of leadership is very important, and the leadership should encourage each team members to think through situations and develop sense of deep involvement. Institutional protocols and systems developed through a collective and consensual process and guide most member management decisions, and all members should have the opportunity to develop these protocols and suggest changes. Specific attention needs to be paid to the nursing cadres because a loss of motivation among them has very direct consequences on outcome. So leadership should be like our previous cricket captain, Mashrafi bin Murtuza. So who is the boss? It is a $1 million question. The surgeons sometimes feel he is the undisputed captain of the ship. Leadership roles are different at different stages of the care. In most mature program, the cardiologist is responsible for preoperative assessment. The surgeon is responsible for planning and execution of decision in the operating room. The intensivist is overall in charge of post-operative intensive care. So willingness to hand over the baton of leadership at each of this juncture while continuing the intensity of overall involvement is important. Rewards and recognition is also a very important key requirement. While all the team members make critical contribution to patients' outcome, not everyone is compensated equally. As a result, there is an extremely high turnover among the least paid members of the team that comes at the cost of compromising outcomes. Serious inequalities in salaries, rewards, and recognition translate into resentment and envy. The leadership and administration need to recognize members of the team privately and publicly as and when necessary. Finally, the regular review of performance. The collective introspection at specified intervals through mortality and morbidity meetings are absolutely vital. The specific contributors to mortality and morbidity need to be identified precisely and addressed in a non-judgmental fashion. Overall outcomes need to be reviewed annually to determine how the unit as a whole is performing. To conclude, assembling a comprehensive team is challenging, expensive, and sometimes unrealistic in this country due to shortcomings in human resources. Modification will need to be made, and the best possible arrangement with the available resources should be used to deliver care. Establishment of a cohesive team requires the organization of a group of team members with diverse skills to come together through good mutual understanding under a leadership that actively promotes team harmony. Better communication, collaboration, and cooperation could have made a substantial difference in patient outcomes. Thanks for patience hearing.
Thanks, Dr. Rezana Rima, for our brilliant presentation on importance of team concept in congenital heart program, guardian needs and crucial perspective. I think she has nicely illuminated the importance of every team member in the successful outcome of a congenital heart program. Now we call upon next speaker, Dr. Judy Baker. His topic is role of transesophageal echocardiography and epicardial echocardiogram in congenital heart surgery, congenital cardiac surgery. Thank you.
You can try to get once. Yes, and this middle is mark.
But I think the pointer works. The pointer works, so it'll be fine. Thank you. Because
Yes,
that won't
you,
reach that.
you can try to forward and backward.
Okay. Thank you. Okay.
Thank you all for coming. Thank you to those of you who put the conference together. Thank you, Chairman and guests. I'm Dr. Judy Becker. I'm from Texas Children's Hospital. I'm an echocardiographer, and I will try and bring us all up to speed for transesophageal echocardiography. Okay, so from a historical perspective, the first TEEs were performed back in the late 1970s. Prior to that, when we went to surgery, if the surgeon needed an image, the thing that was available was epicardial echo. And we'll talk a little bit about epicardial echo at the end of this talk. But once we reached the early 80s, middle 80s, we switched over to transesophageal because it provided a lot more information a lot more easily. And you could get it on and off throughout the surgery if you needed it. We now, in many centers, they exclusively do TEE in the operating room, although in our institution, we do a hybrid combination of both. And commonly in a given surgery, we will actually employ both mechanisms. So at first, initially, when it was initially available, all we had were these, it's an endoscope with a phased array probe on the end of it. And we would have a 5 megahertz probe with a limited number of crystals, and you'd get a fair picture. But it would still give you some information for the surgeon. Now we have these omniplane probes. We have them in adult size and pediatric size, and this thing called a micro mini probe, which allows us actually to do very small babies. The other thing that now has become available is we have 3D on the adult probes. And in our institution, we now, as of a month ago, have 3D on the pediatric probes. So the smaller probes, it's coming. For those of you who are wondering, are we ever going to be able to see 3D in the babies? It is coming somewhere in the next few months. I think it will be available generally. So what are the indications for TEE? The indications are any patient with congenital heart disease who's going to the cath lab or operating room where you need more echo information during the procedure. In an adult, if you can't get a pretty picture transthoracically, we'll commonly employ TEE. It gives us much better imaging because you're immediately behind the heart. You're very close to all of the structures. We look for in a patient, even a patient where we think we're getting pretty images, particularly in an adult-sized patient, where you're looking for thrombi or endocarditis, things in the atrial appendage or back near the pulmonary veins can be missed. And it's amazing how much turns up on the TEE that we would not have been aware of on the transthoracic. So, and again, when we're in the operating room, we do a full transesophageal echocardiogram pre-operatively, a complete study, just to make sure nothing was missed before the surgeon starts his operation. And then at the end of the surgery, we do a slightly abbreviated version of a TEE, but in fact, we're really looking at all structures. We're looking at function. We're trying to make sure that the surgeons, that the valves are not leaky, too leaky to come off bypass, that the surgeon has completed the operation, that the child is safe to go back to the intensive care unit. And let's see, I think that covers that. So in the OR, again, as I mentioned, we do complete anatomic evaluation. We post-operatively, even before they call us back to the operating room to do the post-op TEE, the anesthesiologist will commonly pick up the probe and start looking for bubbles as they're de-airing the heart to make sure that nothing goes into the coronaries. And then they call us and we come down and we do the post-op assessment. And we also, besides looking at the surgery, we look at myocardial function. In the cath lab, TEE has become very important as we're now doing all of these interventions, replacing ASD devices under TEE. They place stents under TEE. And that way we're not interrupting the procedure and we're not getting in the way of the sterile field. There are some contraindications to TEE. There are times when we can't do it. If the baby is too small and or there are problems with the airway, we don't want to drop a TE probe. If a child has a TE fistula, you don't want to drop a TE probe. If there's bleeding in the esophagus or in patients that are older, if they have ulcers, we typically don't want to drop the TE probe. If there's concern in the children who have total anomalous pulmonary venous return, or some of the children who have small left sides and there's concern about pulmonary venous return, sometimes the surgeons have worry that we're going to get in the way of pulmonary venous return, because that's exactly where the probe goes, and it's regardless of the fact that how small we make it, it still takes up space and it can compress the pulmonary veins. And so at times they prefer us not to do a TEE. And in an if you have a patient that you can't sedate for whatever reason, we will not do a TEE. In the adult world, sometimes people will be lightly sedated and they'll do a TEE. I have seen situations where that's done and it's really ugly. In children, we will not do that. A child is totally anesthetized before we drop a TEE probe. Relative contraindications would be esophageal varices, esophageal diverticulum, C-spine abnormalities, distortion in the airway. As I mentioned, coagulopathies. If we think a child has a significant coagulopathy, we will correct it before we drop a TEE probe. And let's see, and a Nissen is considered a relative contraindication. In our institution, the anesthesiologists do not like dropping the probe if we've had a Nissen. There are reasons why we won't drop the probe. This is a stiff endoscope, basically. You have a limited amount of control over it, and so you can do damage. If you push, what we do is you put a little bit of a curve on that probe, an anti-reflection on the probe, and we lubricate the probe, and then you drop it gently in the back of the throat. We do not push. If we're not getting where we need to go, our anesthesiologists are actually very good help with this. We can drop our own probe, but typically in the operating room, the anesthesiologist will drop it for us. And if we're having difficulty dropping it, we give up on it. We either go to a smaller size probe if we can, or we give up on it and do an epicardial echo. This is what the probes look like these days. All our probes are omniplane. We don't even use biplane anymore. If you look at, if you look, we have these very small, like 3.5 or 4 millimeter micro mini probes. The pediatric probe is about 5 millimeters. These adult probes tend to be closer to 9 millimeters. So you have to think about that kind of space in the back of the throat of the individual that you're looking at. I'll commonly go into the operating room and say, I think we can pass a pediatric probe, a 5 millimeter probe in this 3 kilo baby. And the anesthesiologist will look at me like I'm either nuts or they'll try to pass it, won't be able to pass it, and we'll go with the micro mini. The downside of that is that those smaller probes give us the resolution is not quite as good as the larger probes. But the bottom line is you don't want to do any damage to the patient in the process. We do all of, as I mentioned it already, but I'll say it again, we do all of our studies under anesthesia. There's an anesthesiologist or an intensivist at the head of the bed managing the patient so that we can concentrate on the echo and we're not trying to keep track of both at the same time. The children are always NPO before these, because it's general anesthesia. They're NPO before these procedures. We have done an H&P and gotten consent before every one of these procedures. So anesthesia will go by and see the patient. Surgery will go by and see the patient if it's going to the OR. Somebody has talked to the family about the TEE. If it's a child that's not going to the OR, cardiology goes by, including to the cath lab, by the way. Cardiology will go by and see the patient, do the exam, and anesthesia also goes by in those. So they're getting a couple of exams, a couple of H&Ps. We're picking up any problems before they become an issue. The standard monitoring is done all of the kids have an IV. so that you can deal with any problems that come up. And they are monitored in the standard fashion: saturation, heart rate, blood pressure, respiratory rate, just to make sure we're not running into any difficulties. And the anesthesiologist will tell us commonly in the operating room, the heart rate's changing or the saturation's changing. What are you doing with the probe? And then we take care and we start changing our process. Do we need SBE prophylaxis for TEE? No, you should not need SBE prophylaxis for TEE. We're not doing this in a traumatic fashion. You should not need that. However, if somebody has any deep concerns, a dose of antibiotics is not going to hurt the child. I typically do not give antibiotics for TEE. Okay, so what we're doing, everything that we do is to maximize our image resolution, both spatially and temporally. And so we want to use the highest frequencies that we can to get the images that we're getting. We're fairly close to the heart, so we ought to be able to use high frequencies. We narrow our sectors to get better frame rates. And let's see, and when we drop the probe, we're going behind the heart through the esophagus. And there are 3 major places that we look. Actually, in our institution for the children, we concentrate on 2 of those locations. And if we can, we get the 3rd. And I'll go into that in a minute. So we start our study by looking in the mid-esophageal area. And then once we've gotten all our views in the mid-esophageal area, we'll drop the probe further down towards the transgastric region. First the proximal transgastric and then the deep transgastric, and get more views there. In the babies, the high transesophageal region, you're right there at the top of the esophagus, and the probe can come out. So we are very careful about getting those views, and we typically leave those views until after we've gotten the other views to make sure that we don't lose probe placement. There are many different ways you can move the probe. You can move the probe up and down to change your imaging. You can rotate the probe and get imaging that way, side to side in the heart. You can antireflex and retroflex. And now in these omniplane probes, you can also adjust the degrees of the angle at which you're scanning the heart. There are several windows, and this, by the way, for anybody who's doing transesophageal echo, you can get this. It's a poster that's put out by the American Society of Echocardiography, and it shows you all your imaging planes and what you should be seeing. We have one of these up in our lab so that people can refer to it if they need to. So we start with the mid-esophageal plane, and if you just gently push the probe behind the heart, behind the left atrium, and you don't omniplane it, this is the image you'll see. It's a 4-chamber scan. If I antireflex a little bit from there, I'll get the outflow tract, first the left ventricular outflow tract, and then if I extremely antireflex, I'll see the pulmonary outflow tract. If I retroflex from there, I'm going to see the back of the ventricles, and I'm going to see the coronary sinus. So I can do a full sweep of the ventricular septum and the atrial septum just from this view, not doing anything else, just antireflexing and retroflexing. The other thing you can do to get those images as well is you can drop the probe a little bit or lift the probe a little bit. And different TEE practitioners have preferred mechanisms for doing it. The important thing is we can get all of that information from just this one view. There we go. The next thing we'll do once we've looked at the atrial septum and the ventricular septum is we'll start looking up at the atria in the pulmonary veins. So what this top image is showing you here is first the right, and then as we come around the left pulmonary veins, so we can pull those in, even in this the 0-degree omni position. And the other thing you'll notice here is we're seeing the left atrial appendage really nicely here as well. We see the AV valves very nicely in this view. And you'll also see that we're looking at the atrial septum very nicely in this view. If I don't see the pulmonary veins well in the 0-degree omni position, I can then omni to 90 degrees. And what that is my bicaval view. And we'll go into that in just a minute. But from there, we can typically just rotate the transducer, not anteroflex or retroflex, but just rotate. And from there, if we rotate around first to the right, we'll see the right pulmonary veins. And then you can rotate all the way around to the left and see the left pulmonary veins. And so in our pre-op echocardiogram, we actually look for all 4 pulmonary veins. Okay. Then, as I mentioned, so we saw the atrial appendage in the other view, but in fact, you can omni just a little bit and open up that atrial appendage. You can then omni to like 35, 40 degrees and anteroflex, and that will give you a short axis view of the aortic valve. You can also see the coronary arteries from this view. Back here, in fact, we are seeing, there's the left coronary right there. And if we pulled up just a little bit, the right coronary would be coming up here anteriorly. So remember, you're behind the left atrium, as opposed to your transthoracic echo. This is right near your probe, but this is the back of the heart. And this is the anterior chest wall is down here. The other thing that we can see from this 45-degree view is we can begin to see RV inflow, outflow, and somewhere between 45 and 90 degrees, we're going to get a nice open view of that subpulmonary area, which is particularly important for your tetralogy patients. Here we go. And so here in this particular image, they have only omnied to about 40, 50 degrees. But in fact, I commonly will find myself omniing all the way up to 90 degrees to open up that RVOT. To give me this subpulmonary area. And then you see the main pulmonary artery really well from here. You can see the right pulmonary artery as well. We don't typically see the left pulmonary artery well because it dives back into lung tissue. So we tend to lose that. But if there's a ductus, you'll end up seeing the ductus come in right in this region back here at the back of the pulmonary artery. And when the surgeons are going in, particularly in the small babies, we always look for a ductus at the beginning of the case, even if the transthoracic didn't see one, because the surgeon wants to close that. It's kind of mud in his eye, or her eye, if in fact you've left the operating room and you haven't closed a ductus. So then in this if we're in the 90-degree view, particularly for the RVOT, all we have to do is rotate back to the right, and we're picking up the atrial septum in the bicaval view. So in this particular view, what you're seeing here is this is the atrial septum. This is the inferior vena cava down here and the hepatic veins, and it's not quite opened up well, but up here would be your superior vena cava. And so we'll go up and we'll rotate around the atrial septum, first with black and white and then with color, and look for an atrial septal defect. One other thing I didn't mention is in our transthoracic and our TEEs, we always do black and white first. We then do color. We try not to do color compare in these patients because you lose image quality. But you can do that if the surgeon needs to see the black and white and wants to see the flow coming through, let's say to look at an ASD or a VSD. On our machines now, you can do this thing called color compare, which shows you black and white side by side with color. But in fact, we try not to do that unless it's going to give the surgeon useful information. This is just a little bit of additional scanning. When you're looking at the mitral valve, you can actually omni around to 30 and 60 and 90 degrees and then 120 and get a full picture of where your insufficiency or your pathology is with the mitral valve. And I'm not going to go into detail for that because that's going to take a while, but know that you can get at all the scallops. In pediatrics, we very commonly get at that in another way. We go to the transgastric view and look up, and you see the mitral valve in cross-section. And if you have insufficiency on that mitral valve, you can see exactly which scallop it's coming out over. This is just more of the same looking at the mitral valve. Okay, and then we get to the 120-degree view where we're looking at the left ventricular outflow tract, or the inflow and the outflow of the left ventricle, basically. And what you're looking at here is you're looking at, so you're seeing the mitral valve and you're seeing the aortic valve. We can pull the probe up just a little bit to see the aortic root and the ascending aorta. For the adult people, you're going to look here for your aneurysms, and you might pull the probe up even a little bit higher to make sure you don't have an aneurysm going up the ascending aorta. In pediatrics, fortunately, we don't usually have that issue, but it is something we can tackle with the TE probe as well. And then we go to our transgastric views. Now, an important point to make here is we've been androflexing and retroflexing. We never lock our probe because if you lock your probe and then you move it, you can do damage. So we always leave the probe. There's this little lock mechanism on all these probes. I hate it. I wish they never put it there because it's too easy to lock these probes and not even realize you're still locked and try and move your probe and hurt something. So we always make sure we're in a neutral position, and then we gently push the probe into the stomach, watching as we go. And the first thing that we're going to see when we go into the stomach is we'll see the hepatic veins in the IVC. Okay. And by the way, this is in a 90-degree view where you're seeing this particular view. So it's basically the bicaval view, and you're just pushing in from there. If we go to the 0-degree view, right there at the just below the GE junction, basically, you're going to see the crux of the heart, and you see the left ventricle in cross section. That's where I like to look at the mitral valve, where I can see the mitral valve apparatus closing and opening in cross section. And then I turn on color in this view, and I look to see where is mitral insufficiency. And so what this is the posteromedial portion of the mitral valve, and this is the anterolateral portion of the mitral valve. And so I can tell where the insufficiency is. I also look at wall motion here. And so what we'll do is, in my lab, what I typically do is push the probe a little bit further than this position and anteroflex. And that takes me up to the crux of the heart. And then when I retroflex, you're going down to the apex of the heart. And that's a full function study of the left ventricle. Then you can rotate your transducer into basically a 190 to 120-degree view. And that's going to give you the left ventricle and the left ventricular outflow tract as well. And you can Doppler from here. This is a nice angle to Doppler the left ventricular outflow tract. There we go. So going back to the 0-degree view, the 0-degree Omni, when I putting your transducer again in neutral, pushing the transducer a bit further into the stomach gives you the deep gastric views. And what that allows you to do is it gives you a nice view of, it's almost like a subxiphoid short axis, showing you the left ventricular outflow tract and the right ventricular outflow tract. You would just rotate your transducer a little bit to pick up the right ventricular outflow tract. And then you can omni a little bit again and pick up, it's almost like a bicaval view, where you can see the atrial septum and you can see both cavity. And so you can get a lot of information from all these views. Again, we get a complete study before we go to the operating room. Then just to briefly talk about the upper esophageal views, if you come in a neutral position, if you come back to the high retrocardiac image in the esophagus, if you anoreflex a lot, you will end up picking up the pulmonary outflow tract. You get it's actually kind of a nice view for tetralogy because you see that subpulmonary region and the infundibulum, and then you see the pulmonary valve and you see the RPA. We can also see the ascending aorta. We can look at the transverse arch as you're coming out. And if you rotate 180 degrees, not the Omni, but the probe itself, you can look at the descending aorta. And our adult people have now asked us to add those images we didn't used to do those in the pediatric lab. We have now added those images for the adult patients to make sure that we're not dealing with a dissecting aneurysm as we're coming out. This is just more of the same thing. Okay, so when we can't do TEE, and so also sometimes in companion to the TEE, we'll do epicardial scans. And ever since there's been ultrasound available, people have done epicardial in the operating room. So back in the late 70s, they would have been using epicardial already. We use it, let's see, we use it judiciously in the operating room. We always have, we use a 12 millimeter probe, a 12 megahertz probe, sorry. And we always have it available in the operating room to use in conjunction with TEE. Some of our surgeons love it. Some of our surgeons hate it, and it's really a surgical preference. The things it can show you is it can show you out into the branches of the pulmonary arteries. I had mentioned to you, you can't see the LPA well from the TEE. Well, you see it beautifully from epicardially, because you can, literally the surgeon is right there on the top of the pulmonary artery and pointing the probe where he feels he needs to point it. You can look down the barrel of the right pulmonary artery instead of seeing it in perpendicular to your probe, so you can get a good gradient down the right pulmonary artery. You can look at the coronaries directly. On the TEE, I can look at the coronaries, but I'm perpendicular to them again, and so I can't do Doppler easily out into the coronaries. The surgeon can go right down the coronary, particularly after something like a switch operation or an anomalous coronary repair, and then we can look and make sure the flow profiles look normal. We can look at shunts, we can look at the aorta, you can actually look at cardiac function with epicardial echocardiography. The important thing is to know where the head of the transducer is. Your surgeon, you need to work with your surgeon. Many surgeons feel very comfortable with it, other surgeons don't, and don't recognize that there's a top and a bottom to the probe, and so you need to communicate very clearly with your surgeons. Where's the top of the probe? What needs to be on the right side of the screen, what needs to be on the left side of the screen, so both of you know you're talking about the same thing. So where TEE excels over the epicardial, clearly logistics and choreography. The TE probe can stay down for the entire surgery. It doesn't require a sterilized probe, and I didn't mention, anytime you do epicardial echo, what it requires is the surgeon has a sheath, a sterile sheath. You've got the probe. There's only so much length of cord on that probe. You've got to be able to pass the probe to the surgeon sterilely. He's got to get it into the sheath and to the patient with the little bit of cord that you've got. So it takes maneuvering of the machine. The choreography can be pretty difficult. And then once you use it, it's either there in the middle of their sterile field, or it's got to be passed back. And if you need it again, you've got to go through that whole process again. For the TEE, you pass the probe, you leave it in, it's there at the end of surgery. It's nice and quick and easy, and there's a lot you can look at. The other thing is you're not typically compromising the heart when you do it. When the surgeon's doing the epicardial, he does have to press a little bit. So you've got to be concerned about whether there's any compromise there. Apical imaging is possible with the TEE very easily. Apical imaging is very difficult with the probe, with an epicardial probe, because you've got to get under the heart in that sterile field. You've got to keep it all moist so that you've got good contact. That can be very difficult. RV function is difficult to assess with epicardial because you're right there under the transducer. There is nothing in between, and so the image quality is a little bit funky. And there can be complications with an epicardial probe. Again, because you're pressing, you can have arrhythmia because it's in the sterile field. It can be a nidus for infection. And as I mentioned, there can be hemodynamic change. This is what it looks like, what epicardial echo looks like. And what we're seeing here is this is a function study. If I can get this one to run, we're seeing there's a VSD here that you can see. The aortic valve is here. You can see a VSD here. left to right shunt with a little bit of right to left as well, across this VSD. There we go. Here's a picture of an epicardial looking at the pulmonary outflow tract. So this is where the probe is on the top of the pulmonary artery. This is the right pulmonary artery. This is the left pulmonary artery. And you can see the Doppler angle for pulse Doppler is actually pretty good. It's reasonable. Okay. In terms of the last thing that I'll talk about is just the sterilization of the probes, regardless of whether we use a TEE or whether we use an epicardial probe. It's very important that these probes be cleaned properly. We keep our epicardial probes in the operating room, so they don't need to be cleaned beforehand. But if they're being brought to the operating room to be used, they need to be cleaned before the surgery, before they're brought into the operating theater. And then at the end of the case, they need to be wiped down with an enzymatic sponge and then cleaned properly. For our TEE probes, similarly, we wipe them down with an enzymatic sponge at the end of the case, and then we Cydex them, we clean them, and then put them in a sheath so that they're not hanging out in the open in the rooms before we go back to the operating room. We also test our probes, that the TE probes, to make sure that there are no electrical leaks, that there are no cracks in the probes or problems that can cause severe damage in the patient. And that is my talk. Thank you very much.
Thanks, Dr. Judy Baker, for detailing the need of transesophageal echocardiography, indication, contraindication, different views for precisely imaging the cardiac anatomy, and finally the need of epicardial imaging and sometimes transesophageal echo and epicardial echocardiogram supplement each other. We have now there is a program for whole day, so we can allow only limited question and answer session. If you have any question, you can ask question.
Did you ever encounter any injury to the esophagus? Any injury to the esophagus? Injury.
Esophagus. Injury to the esophagus. Hand mic to Dr. Judy, because you can come over to the dais. You can come over to the dais.
So yes, lots of injuries have been reported. Esophageal tears can happen, gastric tears can happen. You can irritate the esophageal lining, which is why I stress you want to keep your probe neutral when you're moving it. Fortunately, I have not run into this, but I trust my anesthesiologist, and if they say we can't pass a certain size probe, I go down to the smaller probe. I may not be happy about it, but I don't question it.
Did you ever encounter any injury?
I myself have not.
If there is anything like that, then how do you fix it?
So if you pass your probe into the mediastinum, that's a surgical emergency. The surgeon needs to deal with that. Yeah, but you have to be your surgeon. Then you need your surgeon's help to close the defect that you have created if you put a hole in the esophagus. Dr. Salim.
Even for the neonates or smaller children, which is not done in other parts of the world, that is US. They are doing a lot of things they can do, but for our practice, normally we don't do more than less than 10 kilogram. We don't practice the TE. In my hospital, it is done lowest body weight is 10 kilogram TEE. Otherwise, if we need any kind of echocardiogram support, we use the epicardial echocardiogram, Perioperative, what she has already explained. Yes, sir, we have to repair it. Yeah, we can do. Yes, sir.
Yes,
And then it's an ICU stay because then you need antibiotics and you've got a chemical pneumothorax as well. It causes all kinds of problems.
Which is quite rare. Now, actually, we're running short of time. We can take a very less number of questions. If there is any comment, just comment from the chairman and moderators, please.
I now we request Professor Ataul Haq, Professor of Pediatric Cardiology, National Institute of Cardiovascular Diseases, Sherbangalore, Dhaka, for his comments, brief comments.
Assalamu alaikum and very good morning. Actually, all the presentations are very good, and we have very little scope to say. Regarding the first presentation, Dr. Rubaba Sarbin, her presentation and deliberation was very excellent and very nice, and particularly the small video clips she added that added extraordinary value. I have nothing to comment on it. Just I want to say that may Allah grant her long, pleasant life. Regarding the second presenter, Dr. Rezwan Arima, that is the doctrine of necessity of the time. What we are trying to do, that is explained by her. And why we are here, that is the answer of her presentation. So the most excellent and most time demanded subject is very nicely presented by her, and really we want to be team member, not group member. So again, we can say many things, but only we can say that may Allah also grant her and us long pleasant life so that we can hear such type of deliberation again and again. And regarding the third presenter, she traveled so much kilometers, perhaps thousands of kilometers from USA, and so painful journey. And after coming here, she deliberated such a nice presentation, and most of us could understand her simple and very scientific languages. So I have nothing to comment, but only one request to her. We want to see her again and again in Bangladesh. Thank you.
Thanks, Dr. Professor Ataul Haq. Now I request Dr. Arman E. Wadud, Associate Professor Cardiac Surgery, Ibrahim Cardiac Research Institute,
Thank you, sir.
for his brief comments.
Thank you, sir, for giving me the opportunity to talk. I actually thank all three speakers for coming here and joining with us in Ibrahim Cardiac. Though I'm an adult cardiac surgeon, I actually thank you very much for participating in our seminar and here for a nice talk. Especially Dr. Rima Appa also actually very courageous presentation, I should say. I think he actually she actually addressed a very good point for the both cardiac surgeon, anesthesiology and cardiology. The conflict is there, but we have to work in harmony. And Dr. Rubaba Sharmin has actually very briefly addressed the situation. And then at the end, Dr. Judy Becker actually is really excellent, very simple, and I think it is very nice and very useful tips for the cardiologist and the anesthesiologist. Thank you, everybody. Thank you for your participation, the questionnaires.
Thanks, Dr. Arman Wadud. Now I call upon Dr. Ruaba Sharmin to take her place as the speaker. Dr. Dezona Rima to take her place as the speaker. Now I call upon Dr. Judy Picker to take her crest for her brilliant presentation. Come on. Okay, thank you.
That brings us to the successful completion of our first session. We will start our second session within a few minutes. Thank you all for your gracious presence and present hearing.
Again, I thank our three speakers. Actually, Dr. Ruva Sharmin. All of you know this timing of intervention and timing of surgery. This is the crucial issue to avoid the complication of disease processes. If you can do the intervention or do the surgery in the optimum time, we can get the excellent result. That's a message, and she has briefly but very precisely outlined in her presentation. Dr. Rizona Rima very brilliantly presented how the team concept in pediatric, starting from diagnosis. In diagnosis, we have the different modalities. I will not go in detail. Then intervention, operation, post-op, everywhere team concept is the main pillar of success in pediatric cardiac intervention, pediatric cardiac surgery. So again, I thank three speakers for the brilliant presentation. I conclude the session here. Thank you.
Assalamu alaikum. And that was an interesting and instructive learning session from our learned panel of speakers. And now we will commence our second scientific session that centers on cardiac imaging. And the session chairperson is Professor S.K.A. Razak, former professor and head of the pediatric cardiology in ICVD, and currently acting as pediatric cardiologist in Anwar Khan Modern Hospital. As panelists, we have with us Dr. Ataul Haq, Associate Professor, Pediatric Cardiology, NICVD, Dr. S.M. Shahidul Islam, Associate Professor, Pediatric Cardiology, Ibrahim Cardiac Hospital and Research Institute, Dr. Liaquat Ali, Professor, Cardiology Department, Ibrahim Cardiac Hospital, Research Institute. And moderator of this session will be Professor Dr. Tawfiq Shahriar Haq, Head of the Department, Pediatric Cardiology, National Heart Foundation and Research Institute. Now I am requesting all the guests to kindly take their respective seats, and the moderator will conduct this session now.
Assalamu alaikum and very good morning and welcome to you all. So we are going to start the second session. We have 4 speakers, and our first speaker is going to be Dr. Farzana Yasmin. She will be talking on diagnostic approach of tetralogy of Fallot.
So thank you, sir. Now we request Professor Abdul Salam, sir, to come on the dais to act as a panelist. Please, sir. Sir, he was in the first session, but due to the traffic jam, he could not join in the first session. Thank you, sir.
Provided the data.
Speaker teachers and dear Larden audience, Assalamu alaikum. I'm Dr. Farzana Yasmin, a specialist and register pediatric cardiology from Ibrahim Cardiac Hospital and Research Institute. Welcome you all on this session. You have already get to know my topics of presentation, that is diagnostic approach of tetralogy of Fallot. Today I will focus on the non-invasive modalities of investigations like echocardiographies, cardiac CT scan, cardiac MRI, and also cardiac catheterization. Four well-known components of tetralogy of Fallot is illustrated here in this. There is VSD, pulmonic stenosis, right ventricular hypertrophy, and varying degree of overriding of aorta.
Or the IT people.
A child with cough can be present with as a pink child having baseline cyanosis or may experience hypercyanotic spells, depending on the degree of RVOT obstruction or pulmonary stenosis. Simple pulse oximetry can give us clue about the cyanosis. Boot-shaped heart in chest X-ray and right ventricular hypertrophy and in ECG can give us clue to some extent. But complete cardiac evaluation is done by echocardiography mainly. But in some cases where echo is insufficient, cardiac CT scan and cardiac MRI are alternative. But as a pediatric cardiologist, I will focus on echocardiography mainly, and we will learn through some cases.
I request Professor Shohid sir to come on the dais, please.
A 3-year-old male child having cyanosis since 2 months of age, 66% saturation in room air, and there is ejection systolic murmur grading over 3/6 on precordial auscultation. And echocardiography revealed large PMS VSD with outlet extension, severe combined pulmonary stenosis, 50% overriding of aorta, and right ventricular hypertrophy. In the second case, the baby also have cyanosis, saturation 78%, and there is ejection systolic murmur. And echo has the same 4 components of tetralogy of Fallot, but here we get severe pulmonary valvular stenosis. I don't know why the images got rotated here. Sorry for the interruption. But the most, so in echocardiography, the most important first point is the location of the VSD. It is mostly located at the outlet extension, and we got in 60 to 70% cases perimembranous VSD with outlet extension. We got 2 types of RVT obstruction. Dynamic RVT obstruction is due to over hypertrophied infundibular muscle contraction, and we get dagger-shaped Doppler signal. And where there is fixed obstruction is maybe due to valvular, subvalvular, or supravalvular stenosis, and we get more tongue-shaped Doppler signal in echoes. We have also comment on coronary arteries in echo. Here is the normal coronary arteries, but 6 to 7% cases, large coronal branch or left antero-descending artery arises from the right coronary artery and crosses the RVOT. And this is very important for the surgeon before performing the tough correction. And we get 25% cases, we get right aortic arch, 10% cases, we get left persistent superior vena cava. Sometimes we get aberrant subclavian arteries, then major aorticopulmonary correlators, and in sometimes it is very difficult to see in echo this structure in some cases. Here is some post-operative, we do follow up post-operative echoes, and we get different type of pulmonary valve reconstruction along with VSD patches. Here, there is bicuspid pulmonary valve reconstruction. And in these cases, there is double path repair of the RVOT. So we get to know that in day-to-day practice, we did echocardiography for preoperatively and for follow-up echoes. But in case of complex cardiovascular anatomy, to see the extracardiac structures like major aorticopulmonary collaterals, the aberrant subclavian arteries, pulmonary arteries, we then the cardiac CT scans comes forward and is of great help. And we have another session on this topic, so we will learn in detail there. Nowadays, the gold standard imaging modalities to see the MRI is the gold standard imaging modalities to see the RV size, RV function, quantifying the pulmonary regurgitant, and also definite tissue characterization. And it is useful in post-operative cases. Then sometimes we need to do the cardiac catheterization. It can identify and define the vascular supply for each of the pulmonary segment, and sometimes we need it for MAPCA coiling in the perioperative period. So to prevent the overflooding of the lungs and early easy weaning from ventilators. So we can see the cardiac anatomy, and is the case from our cath lab. Here you see large MAPCAs here, and after coiling, there is no contrast is passing through the MAPCA. Same here, another cases, there is a very difficult course of a MAPCA, and after coil embolization, there is no contrast is passing through the MAPCAs. There is total occlusion of the MAPCAs, and we see the coil here. So in conclusion, I want to give the message that nothing is contradictory, rather complementary to each other. And we do practice echocardiography, cardiac CT scan, and sometimes cardiac catheterization to guide how the surgeon will perform the tough repair and they suture line so that avoid the damage to the conductive system of the heart. Thank you all for your patience.
Thank you, Farjana Yasmin, for your nice presentation. In addition to this tetralogy of Fallot, there are few associated anomalies like pulmonary atresia with tetralogy of Fallot. And in pulmonary, there is also ASD secondum, that is sometimes we call it, we used to mention it as a pentalogy of Fallot. And 20% of tetralogy of Fallot is
we can call the second speaker, please.
Aortic arch. That is also a good association, and in few situations there is persistent left superior vena cava, about 5% of cases. These are all our association of tetralogy of Fallot. Thank you very much for your brilliant presentation. Our next presenter is Dr. Naharuma Alvi Haidar Chaudhary, and he will speak on role of POE in perioperative congenital cardiac surgery.
Assalamu alaikum. I'm Dr. Naharum Ivy Haidar Chaudhary, Associate Professor Pediatric Cardiology Department of National Heart Foundation. And it's an honor and great pleasure for me to present in this August gathering in front of all. And I also want to thank to Selim Bhai and the organizing committee of BARDEM for arranging such a program. And I think this conference will go and carry on. And today my topic is perioperative transesophageal echo. And this is nicely demonstrated by our foreign faculty, Judy Baker from Texas Hospital. And I am feeling like that the same dish, same ingredient in different style from Bangladesh I'm going to present, and hopefully you will enjoy all. And the history of transesophageal echo. In 1971, the esophageal ultrasound was first reported, and in 1982, the modern era of T really began. And 1999, the American Society of Echocardiography and Society of Cardiovascular Anesthesiologists published the guideline. And before doing the transesophageal echo, we should know the general guideline, the indication of transesophageal echo, and the protocol of sedation and anesthesia, and how to insert a probe and how to manipulate it. And then all of us should know the comprehensive transesophageal echocardiogram imaging and examination, and the specific structure that is identified in transesophageal echo is mitral valve, tricuspid valve, and aortic pulmonary valve, and assessment of the ventricular size and function, and all the venous connection to left atrium, right atrium, and also identify the adult congenital heart disease. And T performed in different sector in different site. Today, my focus is in operating room, perioperative echo. And intraoperative use of transesophageal echo is also, there are various use, but today I'm just focusing on structural transesophageal echo. And the contraindication, relative contraindication, I am skipping because this is already discussed by our ma'am. And before doing the transesophageal echo, the operator must be prepared herself and check the echocardiographic machine, is it working or not? Because after inserting the echo probe into the patient and we found that our machine is not working or probe not working, then it is it is harmful, I will tell. And preparation of patient is important in different setting. We have to prepare in different way. In perioperative, we usually keep nothing by mouth 4 to 6 hours, and we intubate the patient, and we, in neutral position, we keep the probe, and probe insertion is done by the anesthesiologist. And there are 4 graphic upper esophageal level, which we insert 20 to 30 centimeter. And mid is, we see best the great vessel, and then mid esophageal level, we see the atrium and the descending thoracic and the pulmonary artery nicely. And the transgastric, it is 40 to 45 centimeter, and deep gastric, when it is anti-flexed, we can see from the below of the heart, the ventricle nicely. And the better visualizer that we miss sometimes in transthoracic, the posterior structure, that is left atrium, and the left atrial appendage, aorta and descending thoracic aorta, and the posterior venous structure like IVC and SVC, and pulmonary artery and mitral valve, that is best visualized. And how to do this is the T probe, and a gastroscope machine is mounted here, and the imaging surface is demarcated by circular or square shape, and there is a handle, and there is 2 wheels. This is large wheel, this is small wheels of the probe, and there are 2 buttons. This button is necessary for the angulation angle of our echo. And how to the probe manipulation done? We push or advance the probe, and this is so slow motion like our traffic, I don't know why. And it is just advancing, and we can see the inferior structure. Now it is pulling back, it is withdrawal, and this is the superior structure that we can see. And next to the rotated of rightward, which is clockwise, and rotated counterclockwise, that is leftward. And manipulation of the tip of the probe is also anti-flexion and retroflexion by this large wheel. I don't know battery. Anti-flexion is done by clockwise and counterclockwise by the big wheel. And lateral flexion is done by this small wheel, right and left. That is we infrequently do. And the insertion of the probe is different in different settings, and the camera is protected by this cover, and we use the jelly. And there are the basic views that ma'am already mentioned. We have basic 11 views and comprehensive 28 views. And before doing the transesophageal echo, we must know all the views, because sometimes one structure or pathology is not identified as single view. So we have to sometimes modify it. So we have to know this. Among the all views, mid-esophageal 4-chamber view that we got in 0 degree, this is the most valuable and easiest to obtain, and minimal or no manipulation, and it mimics to 4-chamber view of transthoracic parasternal apical 4-chamber view. And what the 4-chamber we are getting, this left atrium, mitral valve, LV, interventricular septum, RV, tricuspid valve, right atrium, and we get the hemodynamics and the shape and the size of and the hypertrophy or the volume of the cardiac status, and also the interatrial or interventricular structure we can see here very nicely, or regurgitation or stenosis we can identify. And here there is mitral regurgitation and due to prolapse of the mitral AML. And this is a case of us which we done in perioperative, with this status post ASD closure, where mitral valve repair, there was vegetation attached with the AML and also in the PML, and this causing the erosion of the mitral valve and producing severe MR, which we get in 0 degree. And this is the vegetation that surgeon has removed perioperatively. And this is the right-sided chamber, and we can see the tricuspid valve movement with some tear. And this is the interatrial septum, which can be delineated in 4-chamber view. Here there is no ASD, and there is large ASD. And this is another case, a 30 years lady, which there is also attached a vegetation in the pad. This is also removed by our surgeons. And this vegetation that is seen nicely here, and there is a PFO flow with left to right shunt. And this is like a fungal-like structure, and this is the vegetation. And after removal, also we have to do transesophageal echo. And when patient is coming from the cross clamp, and we see that the patch is nicely and no vegetation. So to see the residual vegetation also we see. And along with that ventricular status, the volume, the function we assess, and here we appreciate the RV, severe RV dysfunction. And next to that, mid-esophageal aortic valve short axis view. Now we change the sector at 40 to 60 degree, and it is mimic to parasternal short axis view in transthoracic echo. And this is the aorta, this is non-coronary cusp, this is left coronary cusp, and this is right coronary cusp. And this is the right atrium, this is the left atrium, this is the RV inflow, and this is the RV outflow. And here if we see, this is the tricuspid valve. It is not moving. And this is the bicuspid valve. And there is vegetation is attached on the NCC and RCC, and there is a vegetation, and there is a vegetation along with VSD, and there is tricuspid regurgitation. This is also done in surgically, and surgeon has removed the vegetation. Due to VSD, this patient has developed the vegetation, and frequently we got like that. And also sometimes it gives a clue that there is fenestrated ASD, and we can take decision that this patient should be taken on the surgical correction, not by the transcatheter. And 3D also can demonstrate nicely, and this is seen from the LA. And this is another interesting cases that a 30 years male who came to recurrent stroke with PFO, and we did the transesophageal echo, and we found that PFO is full of thrombus, and this mobile structure is the thrombus. Maybe for the dislodgement of this thrombus causes this recurrent stroke. And we sent the patient to the surgeons, and they have taken a thrombectomy and opened that patient. And this is another patient. That patch is also nicely seen by the short axis. And this is the patch, here the patch dehiscence seen in 3D. And after that, just some manipulation can bring this RV inflow and outflow from the aortic valve short axis. And we can get the RV inflow and RV outflow. And this is the anterior tricuspid leaflet. And this is the posterior tricuspid leaflet. It stopped.
Running short of time, just.
I'm almost finished. Just I have 3 or 4 slides. This is the mid-esophageal long axis view, which is mimic to our parasternal long axis view. And the sector angle will be on 120 to 130 degree. And the structure, the LV inflow and LV outflow tract. And we can delineate the A2 and PT component. And this is the right sinus, which is prolapsing, and this is the VSD, and there is the aortic regurgitation, and this is the aortic dissection with hugely dilated ascending aorta, and this is the severe MR due to prolapse of the A2 and P2 component. And this is the ruptured sinus of Valsalva into the RV, and this is left to right shunt, and this is the pulmonary vein, which is delineated in 90 degree with extreme left rotation. We can get the left-sided pulmonary vein, and in 45 degree V-shaped, the right pulmonary vein we get at 45 degree angle. So in summary, that we have to know the cardiac anatomy, then we have to know the pathology, and we have to know the basics of the TE, so that we can do the transesophageal echo. And lastly, I want to thank you all.
Thank you very much, Dr. Naharuma Alvi Haidar Chaudhary, for your nice presentation on perioperative role of transesophageal echo in congenital cardiac surgery. But the presentation has shown by Dr. Naharuma, that is the pre-operative, but we expect in future also Perioperative you have seen. Okay.
Sir,
I was
comments
not
and
there.
discussion can be done later. We're running short of
Okay,
time, sir.
our next presenter.
Moderator, sir.
Yeah. Our next presenter is Nusrat, Dr. Nusrat Ghafoor, and he will speak on CT. She will speak on CT aortopulmonary angiogram. How does it help cardiac surgeons in decision making?
Thank you, sir, for nice introduction. Respected panel of experts and my dear audience, Assalamu alaikum. Next 10 minutes, I'll discuss some congenital cardiac cases where CT angiogram show important information where it can help such a cardiac surgeon and interventionist for the decision making. So we know that every 1,000 live birth, 8 to 10 babies come with abnormal heart in this world. This abnormality start in utero. It could be a situs abnormality, connection, or communication. Whatever the abnormality, simple or complex, it is always be a challenge for a clinician, surgeon, and definitely a radiologist. So accurate assessment of morphology and physiology of malformed heart is very important in surgical management or intervention management and extend them to their life adulthood. In my center now, my experience, we face most cases is tough, and next step we say. In fact, we are facing all type of cases, but I will discuss some common cases where CT angiogram become very important. We know that most common cyanotic heart disease is tough. It accounts 5 to 10% of all CSD. And just a minute. I take the pointer. Okay. This is a sagittal cardiac CT, and we know that the main problem is anterior deviation of coronal septum, like this, which produce 4 component, malaligned VSD, overriding the aorta, RVOT narrowing, and finally RVH. So in CT angiogram, for preoperatively, 4 points is important. One is measurement of pulmonary artery and assessment of degree of stenosis. Is there any pre-RVT course of coronaries? And whether there is any MAPCAS and detection of any additional VSD which needs to be repaired during ICR. We know that TOF can be mild to extreme form. Here is a patient, mild TOF patient, sagittal oblique view. You can see the anterior deviation of coronal septum causing narrowing of the RVOT. This is VSD and overriding the aorta. Good size main pulmonary artery and branch pulmonary. And in 3D view, you can see the LED run anterior interventricular group. That is, there is no pre-RVOT course. So ICR done with good postoperative outcome and echo follow-up. Here, another patient of TOF, you can see more stenosis, RVOT stenosis. But what is important here in the 3D images from backside, this is descending thoracic aorta and a small MAPCA. One can follow the course of the MAPCA and diameter of the MAPCA. As MAPCA is small, so ligation is enough during surgery for this patient. I said this TOF acid can become with extreme TOF, that is pulmonary atresia. And coronal oblique view, you can see the confluent branch pulmonary, but there is no main pulmonary artery. Here is the same. And this is the component of the TOF. And what I want to give importance here in these 2 film. This is the aorta and multiple large MAPCA. And one can follow the course of the MAPCA, whether there is any stenosis and anastomotic size, measurement of the MAPCA, number of the MAPCA. So MAPCA could be come directly from the descending aorta or indirectly from subclavian, coroners, even colectomy. Actually, yesterday I reported a case, all the MAPCA come from both subclavian and colectomy, very unusual. So what I want to say that CT angiogram can clearly road mapping the all MAPCAs, like number, location, size. So surgeon can decide whether ligation or coiling according to size and or transplantation. Like for this type of patient, unifocalization is important. That is, transplant the map curve from descending thoracic aorta into the pulmonary artery. Otherwise, after operation, lung will be blooded with excess blood. So post-operatively, wheeling would be difficult for this patient. This is another extreme top. When there is a pulmonary atresia, lung can get supplied either by MAPCA or by the PDA. So it's a rare variety of top with absent pulmonary valve. What happened here, when there is no pulmonary valve, so pulmonary artery and branch pulmonary get sometimes hugely dilated, causing compression of adjoining bronchus. So this information is very important for the surgeon, because during operation, it's very important to reconstruction of the bronchus as well as dilated branch pulmonaris. Okay. We know that 5 to 7% of associated with anomalous coronary arteries, and it is extremely important information for surgeon. Actually, without seeing the coronary, it's very difficult for surgeon to start operation. And most commonly involved artery is right coronary artery. You can see in the 3D images, RC come from the left side and crossing over the RBOT. So if surgeon start operation without knowing this, there's every possibility to injury the RCA. This type of patient needs different operative approach like PA2 RB, RB to PA conduit to save this artery. So again, possibly CT angiogram is the only modality can guide the surgeon about the detailed information about the coronaries. Second most common what I face, that is total anomalous pulmonary venous dryness. We know that all the pulmonary vein anomalously drain into either RA or systemic circulation rather than LA. There are 4 types of TPAVC. Most common variety supracardiac TPAVC. And here you can see that this is backside 3D view. All the pulmonary vein usually form a confluence back to the LA. And this is a vertical vein which join the brachiocephalic and ultimately drain into the SVC. And this confluence, this all pulmonary vein may drain SVC directly. Second common variety is cardiac type. That is all the pulmonary vein first form a confluence and drain either directly RA or into the dilated coronary sinus. It's a rare variety infracardiac form. Again, you can appreciate all the pulmonary vein form a confluence, runs downwards, cross the diaphragm and drain into the portal vein. But I want to give importance that what is important this type of patient? Detailed road mapping of all the pulmonary venous pathway, the drainage diameter, and whether there is any obstruction or not. If there is any obstruction, so that type of patient needs early surgery. Another variety, partial anomalous pulmonary venous connection. It is one of the cause of adult heart failure with unknown etiology. Most commonly involve vein. We know that right upper or middle pulmonary vein usually drain into the lower SVC with always associated sinus venosus ASD and right heart dysfunction. But CT angiogram, again, possibly the single most important modality can find out this culprit vein. After pulmonary window, it's not very common one, rare one. It's a connection between the aorta and pulmonary above the both semilunar valve. So you can see the connection, but important information here, sometimes left coronary artery arises at the edge of the MPA or pulmonary artery. So this information is very important, because during operation, rerouting of the pulmonary artery, coronary artery into the aorta is needed. So CT angiogram is very helpful to find out that type of abnormality. Coarctation, it's a congenital narrowing of the distal arch of the aorta, distal to subclavian artery under the junction of ductus and aorta. So it could be infantile variety, usually associated with hypoplastic aortic arch, or juxtaductal variety, usually without hypoplasia, aortic arch hypoplasia. Here is a small girl. You can see that there is a severe narrowing, 6.3 mm from left subclavian artery, with hypoplastic median distal arch. And another patient, discrete severe narrowing just adjacent to subclavian artery. So distance from the subclavian artery is very important. If it is very near to subclavian artery, there is barely landing point to put an angioplasty or stent. So surgeons prefer this type of cases. And when there is a hypoplasia, surgery is preferable. Usually reconstruction of hypoplastic arch done homologous pericardium. So we have go through some common cases. We are facing almost all type of congenital cases, and you can see after seeing these cases how CT angiogram help or guiding the surgeon or intervention cardiologist in their treatment plan. Actually, it is said that CT angiogram is the eye of the cardiac surgeon. These are my reference, and before I stopping, I would like to proudly share one thing. We are doing significant number of cardiac CT in our Ibrahim Cardiac Center, and almost every day 2 or 3 cases. And I'm hoping that other center also start to doing this very soon. And I would like to express my gratitude all the clinicians and cardiac surgeon, cardiologists referring cases to our center and keeping faith on us. Thank you very much.
Thank you very much, Dr. Nusrat Ghafoor, for your wonderful speech. Our next talk is going to be on role of ultrasound in post-congenital cardiac surgical patient management. And speaker is going to be Dr. Diego Caselli. I hope I got the name right.
All right. Well, good morning, everybody. My name is Dr. Diego Casale. I am an adult intensivist, and I work in the adult congenital heart disease ICU at Texas Children's Hospital in Houston, in the United States. And I just want to thank the organizers and the distinguished guests for having us over here. And today I'm going to talk about the role of point-of-care ultrasonography in the intensive care unit. We're going to start with the role of echocardiography, both transthoracic echocardiography and transesophageal echocardiography in the management of patients both pre and post cardiac surgery. Of course, there's plenty of advantages in having point-of-care ultrasound available in the intensive care unit. It's a modality that can be performed at the bedside. It can be repeated multiple times to assess different interventions that implement on our patients. And it really has no disadvantages for the patient. There's no ionizing radiation involved. Although there is a learning curve, it's definitely something that can be implemented quite readily at the bedside. In the ICU, in the United States, we perform both transthoracic echocardiography and transesophageal echocardiography in the intensive care unit. Sometimes in the middle of the night when we don't have cardiologists available, we as intensivists perform the transesophageal echocardiography in a limited fashion to answer hemodynamic questions that we have. So we're going to start focusing on the TE first, and there's actually 4 main positions for the ultrasound probe that we like to obtain in point-of-care ultrasonography. So the first position is the left peristernal position. From there, we can obtain a peristernal long axis view. We can obtain a peristernal short axis view. After that, we typically move to the apical position that is located at the nipple area. We obtain typically a 4-chamber view at the apical level. Then we move to the subcostal area. In the subcostal area, we can typically perform subxiphoid views where we can get a nice view of the 4 chambers of the heart. And in the subcostal area, we can also obtain a view of the IVC and get an idea of what the diameter of the IVC is, what the respiratory changes are with the diameter of the IVC. And from that, we can kind of gauge what the right atrial pressure is going to be like. So I'm just going to show you the main views that we obtain in point-of-care transthoracic echocardiography. We're going to start with the first one, the peristernal long axis view. So in this position, we have the indicator facing the right shoulder of the patient, and then we see left atrium, mitral valve, left ventricle, LVOT, and aortic valve. We also see the RVOT in this view. We can kind of like start gauging what the function of the right ventricle and left ventricle is. If we remain in the same position where we just tilt towards the right ventricle, we obtain what's called a right peristernal long axis view. In this view, we can actually get a good view of the right atrium, of the tricuspid leaflets, and of the right ventricle as well. This is a nice view, for example, if we're interested in measuring the RV function and obtaining like TAPSE, for example, we can certainly like obtain it from this view. Moving on, we change position of the probe. We get to the peristernal area, and we start with a peristernal short axis view. In this view, essentially, we start looking, superiorly. We see the right atrium in this view. We see the tricuspid valve. We see the RVOT. We see the pulmonic valve. We see the aortic valve, inner atrial septum, and left atrium. And then from there, we fan down, and then we get to the peristernal short axis view mitral valve. This is the same view, just flipped from TEE. And essentially, this is now anterior. This is posterior. So we see the anterior mitral valve leaflet and the posterior mitral valve leaflet. We can gauge the origin of a mitral regurgitation from this view. Then if we fan a little bit lower, we get to the peristernal short axis mid-ventricular view. Here we see the papillary muscles. And in this view, we have the anterolateral papillary muscle and the posteromedial papillary muscle. Moving on, we go to the apical view, and there's many views that we can obtain from the apical position. The main one and the most important one to assess patients in the intensive care unit is actually the apical 4-chamber view. So in this view, we can actually appreciate the size of the right atrium, size and function of the right ventricle, presence or absence of tricuspid valve pathologies. And the same is true for the left atrium, the mitral valve, and the left ventricle. We can also fan the probe a little bit higher. We can obtain a 5-chamber view where we can see the LVOT and the aortic valve. If we fan the probe a little bit lower, we get to see the coronary sinus view. And sometimes coronary sinus problems are issues encountered post-cardiac surgery. Moving on to the subcostal view, we're just going to focus on 2 views. So the subcostal 4-chamber view. In this view, we can assess size and function of the 2 ventricles, presence or absence of pericardial effusions. And then we can also assess the size and respiratory variation of the IVC. The difference between this view and this view is basically the position of the probe. So the probe is oriented towards the left side of the patient in the subcostal view. So the indicator is towards the left side. In the IVC view, the indicator is actually towards the patient's head. I'm not going to really focus too much time on TEE because the other speakers have already gone through it. I just want to mention that, having the availability of a TEE machine in the ICU, having the possibility of performing TEE at the bedside is actually quite useful in the intensive care unit. I've had many patients that are hemodynamically unstable post-cardiac surgery, where, getting a cardiologist to come at the bedside right away and figure out what was going on was challenging. And so having, an intensivist available to perform TEE is actually quite useful and can change the management and the outcome of the patient. That doesn't take away, of course, from the importance of performing a full study. We always obtain a full study after our point of care TEE study. But in the immediate period, it's quite important to be able to, implement interventions right away. I just wanted to focus on other uses of ultrasound, and we can start with lung ultrasonography. So lung ultrasonography is actually something that is very, very easy to perform, can give us a lot of information about why a patient is hypoxic or even hemodynamically unstable in the intensive care unit. It just requires a linear probe, which is the same probe that we use to place central lines and arterial lines in the intensive care unit. So lung ultrasonography relies on the presence or absence of artifacts. So normally, we used to think in the past that lung ultrasonography cannot be performed because lungs are full of air and sound waves are going to be scattered away and we're not going to get any useful information from it. That is not true. In fact, lung ultrasonography and all the artifacts that are produced by the presence or absence of air in the lung can actually tell us a lot about what's going on in the lungs. So this is an example of a normal patient where we have the linear probe placed with the indicator that is actually facing the head of the patient. We see a rib with its shadow. We see the pleural line over here, which is this hyperechoic line. And then we see normal lung parenchyma down here. So we know that it's normal lung parenchyma because we see the first artifact of lung ultrasonography, which is A lines. It's when sound waves are scattered at different depths and it produces these horizontal lines, essentially. When there is, for example, pulmonary edema in a patient, both pre and post cardiac surgery, we're going to be able to actually assess the presence and the also response to interventions by quantifying the amount of B lines that are present. So each time there's water or any type of fluid in the alveoli or in the interstitium, we get to see these deep vertical lines. These are called B lines, and the presence of 3 B lines or more per lung field is considered pathologic and indicates what we call alveolar interstitial syndrome. So the presence of any type of fluid, it can be water, it can be blood, it can be pus in the lung parenchyma. say you have a patient that has pulmonary edema and comes in heart failure, you do lung ultrasonography, you see a lot of B lines in their lung fields, and then you diurese the patient, and a couple of days later, you want to repeat lung ultrasonography, you can actually see that B lines completely go away, and you finally have a normal A line pattern in both lungs. It's also very important to assess the presence or absence of a pneumothorax. So we're all used to like getting a chest X-ray after placing a central line, but actually doing lung ultrasonography right after we do a central line, especially when we have concerns over the presence or absence of a pneumothorax, can be even more sensitive than a chest X-ray. In fact, in good hands, sensitivity of lung ultrasonography is actually as good as sensitivity of a CT scan of the lungs, and certainly much better than chest X-rays. Another use of ultrasonography in the ICU is to obtain information about the presence or absence of DVTs in our patients. So say there's a patient in the ICU that is hemodynamically unstable, you suspect that they might have a pulmonary embolism, placing the linear probe in the leg area and kind of scanning from the inguinal ligament all the way down to the knee can give us a lot of information about the presence or absence of DVTs that could explain the hemodynamic instability of our patient. And this is actually part of a protocol that we use for hemodynamically unstable patients or coding patients in the intensive care unit. Another use of ultrasonography is actually described in the use of FAST. So each time we have a patient, for example, a trauma patient or a patient where we suspect any sort of like hemodynamic catastrophe that might come from the abdominal area, performing a FAST is actually quite easy and actually quite rapid as well. There's four main areas that we focus on. So the first area is the Morrison's pouch. We take a look at the presence or absence of free fluid there. Then the splenorenal space, and again, we see or don't see fluid in there. The suprapubic area, so we look for free fluid around the bladder. And then if we haven't performed already an echocardiography in these patients, we can actually see in the subxiphoid area the presence or absence of a pericardial effusion. Other uses of ultrasonography in the intensive care unit are renal ultrasonography. When we suspect that a patient has acute kidney injury, we kind of want to get a quick answer about the presence or absence of a post-renal cause. We can look for the presence or absence of any hydronephrosis. And then we can, in the right patient, we could also get information about the vascular supply to the kidneys. We are all familiar with the use of ultrasonography for vein cannulation. It's actually much easier to obtain central lines and A lines with ultrasonography. It takes much less time. It's safer for the patient, and it allows you to kind of know the anatomy beforehand. It allows you to follow the tip of your needle and know exactly when you're actually inside the patient's blood vessel. It can also confirm where the wire is going, because sometimes, even if it feels like it's going down the right path, it might actually turn up into the neck, or depending on the anatomy of the patient, it can go in places that are different than the right atrium of the patient. Having ultrasonography at the bedside is also very useful to confirm the placement of the line, so much so that there's many studies coming out of France that say that there's not even a need for a chest X-ray post central line placement. We can obtain all the information we need from an ultrasound at the bedside. We can see if there's a pneumothorax or not, and by injecting some saline into the distal port of the central line and having an ultrasound placed in the subxiphoid area, we can actually see the presence or absence of air, essentially, or air bubbles, and we can see where the saline is going. That confirms the location close to the right atrium. A couple of more uses of ultrasonography in the ICU. So it can be used for confirming the location of an ET tube or of a tracheostomy. And I have a picture here of an ET tube with its balloon that is creating a nice shadow beneath the trachea. And the same thing, we can look at tracheostomy to make sure that it's in the right position. We can also delineate the vascular anatomy prior to performing a bedside tracheostomy. That way we know to avoid certain blood vessels at the bedside. There's also a use of ultrasonography at the bedside for a transcranial Doppler assessment of flow in the cerebral artery, in the middle cerebral artery. And that's useful because many of our post-cardiac surgery patients do develop brain injury. Some of them develop intracerebral hemorrhages on pump. Other ones, they develop significant amount of coagulopathy post-operatively. And they're not all hemodynamically unstable, not all hemodynamically stable enough to be able to go to CT scan. So being able to assess the presence of the cerebral blood supply and the type of cerebral blood supply in the middle cerebral artery is actually quite important. It can give us information about, for example, the presence of vasospasm in a patient with a subarachnoid hemorrhage. And the final use of ultrasonography that I want to describe at the bedside in the ICU is ocular ultrasonography. So we can actually look at the patient eye and we can gauge some information about the presence of intracranial ICP elevation, intracranial pressure elevation. So we can look at the eye right here. We can also look at the size of the optic nerve sheath. So you see this area right here that I'm pointing at, that's the optic nerve sheath. We typically look at the diameter of it. Typically it's like 2 centimeters or lower. That's a normal diameter of an optic nerve sheath. Say you suspect that your patient might have increased ICP or might even be herniating at the bedside, and you're not comfortable bringing your patient to CT scan because you think they're going to die en route. Something you can do at the bedside and just put a tegaderm on the patient eye, close the eye, put a lot of gel on top of the tegaderm, and then scan the eye. And I show you here an example of a patient with an elevated ICP, and you can definitely see here, even without measurement, that this optic nerve sheath is quite dilated. So it's certainly more than 2 centimeters. And that gives us information at the bedside that can change management of our patients. And with that, I thank you for your attention. Thank you.
Thank you very much for the brilliant presentation. We are really short of time. We are going to take 4 quick questions for 4 speakers, if anyone has any. Yes, please.
Hi, I'm Richard Hubbard. I'm one of the foreign visitors. I had one question for our speakers was about the use of intraoperative TEE in terms of how often we're using it in Bangladesh, which centers are using it, what kind of lesions we're using it
Dr.
for.
Naruma, how frequent are you using TE in your post-operative cases?
And also, where are the areas of growth that you could see?
We are not doing the frequently in all cases. We do the epicardial, but transesophageal that we need valvular repair. We need assessment of the residual cases if we do. And also that cases I have shown that post-operative cases, post-operative complication that we see, and after removal of our valvular repair, what is the ventricular function is also, and also the repair of prosthetic valve also we see that.
My hospital we are doing the TE for after the tetralogy fellow repair mainly to see the gradient in the RVOT or whether they are generally residual or not. And other valvular repairs like aortic valve repair or mitral repair, whenever we do routinely for those cases. For only simple ASD, VSD, we don't do practice routinely, but yes, if we're in trouble, then we call our cardiologist to the team.
May I like to bring
I'm
the
myself from
attention-
I'm an anesthesiologist from Square Hospital. and where we have been practicing almost all cases under transfemoral, especially in case of valve repair, congenital disease, and mostly we are doing aortic surgery there. So the aortic surgery actually it invites a lot of TE interrogation during surgery, during repair, and then after repair and before sending patient to the ICU would be a final transfemoral interrogation, and then we satisfied, then we hand over the patient to the ICU. Thank you very much.
I like to bring
Comments will be later, sir.
Dr. Judy regarding perioperative echo for seeing the repair of tetralogy of Fallot and how the RVOT is behaving, how the cusps Dr. Selim has put for a reconstruction of pulmonary valve has because of pulmonary artery is anterior to the heart. So it is transthoracic view is better than esophageal. Usually I do perform T in my center. So sorry, we are running short. I will personally talk to you because there is a
Maybe over a cup of coffee
Sir,
after
sir,
the
our
session.
inauguration program will be will start just now because our honorable chief guest he just arrived. So we just want to hand over the crest to the speakers.
Okay.
Before that.
So let's hand over the crest to the speakers. First, I would like to request Professor Shohidul Islam sir to hand over the crest to Dr. Farzana Yasmin.
Yeah, please.
Speaker চলে আসেন সবাই। Professor S.K. Razzaq sir to please hand over the mic to crest to Dr. Naruma.